internal medicine at Georgetown University and hospitals, and a fellowship in endocrinology at the University of Pennsylvania School of Medicine. He's board certified in endocrinology, diabetes, and metabolism, as well as internal medicine. Dr. Shaker is a professor of clinical medicine at the Medical College of Wisconsin. He practices at North Hills Health Center in Menominee Falls and the Clinic for Osteoporosis and Calcium Disorders at Freighter Hospital. Dr. Shaker's research interests include high or low blood calcium and parathyroid disorders, osteoporosis associated with intestinal disease or surgery, and calcium and bone disorders. Please welcome Dr. Shaker.
Thanks, Ted. Am I mic'd okay?
Yes. Yep.
Thank you very much for inviting me up here to speak. This is one of my favorite topics. Just as an introduction, my only conflict is listed here. They make a medication for hypoparathyroidism, which I will not be discussing. So I'd like to, as an overview, talk about the PTH calcium vitamin D system, talk a little bit about PTH-independent hypercalcemia, spend most of the time talking about PTH-dependent hypercalcemia and evaluation and management of primary hyperparathyroidism, of course, the most common cause of hypercalcemia. So I'm going to start with a case that we'll come back to. This is a 68-year-old woman. She was no doubt hypercalcemia on routine labs. She has really no symptoms, no stones, no fractures. She feels well. There's no family history of hyperpara. She has hypertension and type 2 diabetes and is on an ACE inhibitor, hydrochlorothiazide, and metformin. And looking back at her record, she has hypercalcemia for at least 5 years. On exam, her BMI is 30, and she's otherwise normal. Her calcium is 10.9 with an upper limit of about 10.2. Phosphorus, 2.9, creatinine normal. PTH in the normal range at 55. Urinary calcium on the low side with a low calcium to creatinine clearance ratio. And vitamin D, marginal, but not terribly low. So I always like to start with a little bit about the history. So the relationship between calcium and bone metabolism in the great Indian rhinoceros is that the parathyroid glands were first discovered in the great Indian rhinoceros. Sir Richard Owen dissected the Indian rhinoceros in his back garden in 1849. In 1850, presented a monograph on the compact yellow glandular bodies attached to the thyroid that at that time were called the glands of Owen. So just to review for everyone, how calcium metabolism works. If your calcium is low, it is sensed by the calcium sensor on the parathyroid glands, and they will make parathyroid hormone. The parathyroid hormone will increase bone resorption, increase production of the active form of vitamin D, 125 dihydroxyvitamin D of the kidney. That will increase gut absorption of calcium and will increase calcium reabsorption in the kidney. All three of those will serve to protect the serum calcium. It will also cause phosphaturia. Just as a note, the nephrologists well know 125D also feeds back as well as calcium and suppresses parathyroid hormone. And a hormone that you may or may not know about, but you will hear more about, is FGF23. It is one of the so-called phosphatonins. It is made by osteocytes in bone cells and causes phosphate wasting and decreases the active form of vitamin D. And it's important in some inherited disorders like X-linked hypophosphatemic rickets, also an acquired disorder called tumor-induced osteomalacia, as well as tumoral calcinosis, but really important in chronic renal failure. One other thing you should know about, and that is we activate vitamin D to 125D at the kidneys, but there is an enzyme, which I'll mention briefly in a few minutes, called 24-hydroxylase, that deactivates both 25D and the active 125D. So how about PTH-independent hypercalcemia? Most common cause is malignancy, either by production of PTH-related protein, which we'll talk about, bone metastases, and sometimes unregulated production of activated Another fairly common cause is calcitriol-mediated hypercalcemia. So calcitriol, the same as 1,25-dihydroxyvitamin D. This occurs in granulomatous disorders like sarcoid and tuberculosis, and a bunch of other inflammatory disorders where you, in an unregulated way, make 125-D. And also occurs in lymphoma. Hyperthyroidism can cause hypercalcemia. Hyperthyroidism, particularly when severe, increases bone resorption and bone formation, but resorption more, and you can get hypercalcemia in this setting. In the old days, they had milk alkali syndrome. Remember, that was when people used to think that, I think it was the sippy diet, when people with peptic ulcer disease would eat milk and cream all day. Nobody does that anymore, but there have been people who take huge amounts of calcium carbonate and get the actual same syndrome. And sometimes this is actually surreptitious use, people who are, hide it from their physicians that they're getting huge amounts of calcium carbonate. Immobilization, if you're totally at bed rest, you'll get increased bone resorption. This tends to be the biggest problem in young men with spinal cord injuries who have a large skeleton that then they start to lose a lot of calcium from, and it exceeds the ability of the kidneys to excrete it. Adrenal insufficiency can sometimes present with hypercalcemia, and there are a variety of other rare causes that I won't mention. Now, how about calcitriol-mediated hypercalcemia? I mentioned this before. This is a list of the things, it's in your handout, I'm not going to go over this, that can cause unregulated extrarenal production of calcitriol. By far the most common is sarcoid, in at least the US, and lymphoma the second most. But I want to mention one other. What's been described recently are mutations in the enzyme that breaks down, that deactivates vitamin D. And there are now several families described, I've seen 2 now, who have hypercalcemia that looks like sarcoid, but it's due to mutations in this enzyme. And what's becoming clear is there are milder and milder forms of this. And some patients just present with hypercalciuria and kidney stones, but never get, frankly, hypercalcemic. And I think we're going to ultimately see that some of the forms of idiopathic hypercalciuria are caused by this mutations and the inability to deactivate vitamin D. I mentioned PTH-related protein. This is the thing that commonly causes humoral hypercalcemia malignancy. It was actually predicted in 1941 by Fuller Albright. Many of us consider him the father of modern endocrinology. And he predicted this in a CPC in the New England Journal of Medicine in describing a patient with hypernephroma who had hypercalcemia. Obviously, it wasn't discovered until many, many years later. It's most common in solid tumors, breast, lung, kidney, and squamous. It looks a little like PTH at the N-terminus, but it's not measured with our parathyroid hormone assays. It's found in high concentrations in milk, so women put it into the milk, and it's important in fetal development. Now, a review of 138 patients with PTH-RP mediated hypercalcemia, recently published. Solid tumors by far the majority, hematologic malignancies a small percent, but also a handful of benign conditions have been described. And it's been called, I put a list of those in the handout, the hypercalcemia of benignancy. But things like weird ovarian tumors, mammary hyperplasia, things like that. So there are a handful of things that can cause this even in a benign condition. So how about medications? Well, I'm going to discuss 2. There's a big list, but I'm going to talk about thiazides and lithium because I think those are the 2 most important and the most frequent clinical problem. So thiazides decrease urinary calcium excretion. They maybe cause a little volume contraction. There's some data that they increase PTH, and they may just unmask hypercalcemia, and there's questions of whether they induce parathyroid gland enlargement. That said, most patients with thiazide-associated persistent hypercalcemia have an underlying hypercalcemic disorder, even if you stop the thiazide. So this is kind of what I recommend if you have a person on a thiazide with hypercalcemia. If the PTH is suppressed, you need to stop the thiazide and evaluate the patient, because you need to look for a cause of PTH-independent hypercalcemia and make sure sure you're not missing anything serious. If the PTH is high or inappropriate, and the hypercalcemia is mild and stable, and you're not likely to recommend, as an elderly patient, you're not going to recommend parathyroid surgery, I don't think you even need to stop it. You can just monitor the patient. If the hypercalcemia is significant or the patient is appropriate for surgery, for parathyroid surgery, I think you need to stop the thiazide and reevaluate. Lithium changes the set point for PTH, and it results in a higher calcium needed to lower the PTH via the calcium sensing receptor. And it may actually sometimes have a low urine calcium with lithium-associated hypercalcemia, because it looks like the calcium sensing receptor thinks the calcium is lower than it is. So the calcium sensing receptor at the renal tubule holds on to calcium. There are many patients who do turn out to develop primary hyperparathyroidism, and in those patients, multiglandular disease is more common, and consequently, persistent or recurrent disease is more common than the typical patient with primary hyperparathyroidism. So how about PTH-dependent hypercalcemia? Obviously, that's most patients. Well, the most have sporadic hyperpara, by far, single gland disease. Some have multiple gland disease, and thankfully, parathyroid carcinoma is rare. But it's important to remember when we're evaluating patients with primary hyperpara that there are a number of familial conditions associated with hyperpara: MEN1, MEN2, something called MEN4, which is really a kind of a phenocopy of MEN1, but a different mutation. And then something called the hyperparathyroidism jaw tumor, in which case syndrome, in which case, a syndrome where people have primary hyperpara and several other tumors, including sometimes kidney cancers and parathyroid carcinomas. There's also patients with familial isolated hyperpara. And these are families who you have multiple family members with hyperparathyroidism, but they don't have any of the other syndromes. And if you do genetic screening on those patients, about a third have a mutation of one of the more common hyperpara genes. I'll talk about familial hypocalciuric hypercalcemia. This is a rare condition whose importance is that we need to distinguish it from primary hyperpara before we send patients to surgery. Rare cases of autoimmune hypocalciuric hypercalcemia, which I won't go into. And then there are ectopic PTH from non-parathyroid tumors. There are a handful of cases reported, but it's quite rare. So FHA, familial hypocalciuric hypercalcemia. These patients have asymptomatic, modest, lifelong hypercalcemia. It's not acquired. And looking at all labs is sometimes very helpful. They have a low urine calcium. The PTH is not suppressed. It's either normal or elevated, but inappropriate. The magnesium is high, autosomal dominant, and it's not cured with surgery. Surgery is inappropriate. The only way you cure them is by making them hypoparathyroid, and they don't need to be cured. They don't have a disease that causes problems. Most patients have mutations of the calcium sensing receptor. So what happens is the calcium sensing receptor on the parathyroid says it's not sensing perfectly normal. It says the calcium isn't high enough. It makes a little more PTH and raises the calcium to a higher set point. The reason that urine calcium is so low is the calcium sensing receptor on the renal tubule is sensing the same thing. The calcium's not high enough. Hang on to all the calcium that I can. If there's consanguinity and people inherit 2 copies of this gene, there is a surgical condition, neonatal severe hyperparathyroidism. What's been discovered in recent years is there are at least 2 other genes that cause FHH. Obviously, that complicates things sometimes when we're trying to distinguish these patients. So, how about the more common thing, primary hyperparathyroidism? If you look at studies in the United States, in recent years, the mean calcium is 10.6 to 10.8, normal to high PTH, normal to high urine calcium. Some people have intermittent hypercalcemia, and then there's this variety, normal calcemic hyperpara, that I'll talk about at the end. In the 60s and 70s, radiation treatment was used to treat a number of benign conditions. Hotspots in that were Chicago and Milwaukee, treating acne, thymic enlargement, tonsillar enlargement, and these patients are at high risk for papillary thyroid cancer and primary hyperparathyroidism. In my practice, which of course is skewed, I see a lot more radiation-associated hyperpara than I see radiation-associated thyroid cancer. Most of the patients have adenomas, and about 10 to 20% have multiple gland disease. So I'd like to start with how would I approach, what's the basic workup for a patient with hypercalcemia? Yeah, do a history and physical, look at all labs, is it new, is it old? Check a family history, is there family history of anything associated with hyperpara? Always get a repeat level. And check a PTH. And break it down into two groups. If the PTH is suppressed, and the patient has a known malignancy likely to be responsible for it, may not need any workup. They may have an obvious cause, and you may not need any workup. If they have no known cause, you have to evaluate for cause, and that may involve checking SPEP and UPEP, activated vitamin D, TSH, PTH-related protein, and imaging, depending on what you find along the way. If the PTH is elevated or inappropriately in the upper normal range, then you need to work them up for primary hyperpara. And I'll talk a little bit of what the recent guidelines say, but one thing that's important is a 24-hour urine calcium and creatinine, a bone density, a vitamin D level, and probably some imaging for kidney stones. So, can you be fooled? And there's one thing I want people to take out of this. Occasionally you can be fooled. There can be a low PTH and it's really primary hyperpara, and there's a handful of reasons why that could be. And there could be a high PTH that really, and it doesn't reflect true hyperpara, and there are a handful of problems that can cause that. But the one I want you to remember is biotin. Patients are now frequently, I see at least one a week, probably more, new patient that's on biotin. As it turns out, many of the platforms for immunoassays use biotinylated antibodies, and it interferes with the PTH and other hormone measurements, and it can be in either direction. The first report of this was with people who turned out to have primary hyperpara. They couldn't figure out the cause of the hypercalcemia because the PTH was suppressed. And then they measured on a different platform that didn't use biotinylated antibodies in the first reports. But it turns out, even more importantly, that it affects the TSH assay similarly. So we all take care of tons of hypothyroid patients. And it can cause artifactual high or low TSHs. So if you have patients on biotin, I'm not sure what dose it requires, nobody knows. I have them stop it for a week or two before you do labs. I don't care if they take it for their hair and nails, but I think it should be stopped before non-urgent labs. So one takeaway. Okay. Let's talk about the skeleton in hyperpara. This is, of course, the most famous case. Captain Charles Martel, he was a merchant marine, and this is him before hyperpara ravaged his skeleton, and this is after. Unfortunately, it took him 7 operations to find his mediastinal parathyroid tumor, and he died several weeks later because they had taken out the other parathyroids from tetany while passing a kidney stone. So this is from a patient with severe hyperpara. They saw this lytic lesion, they thought he had cancer. Well, this turns out to be a brown tumor. That's this here. It's a mix of multinucleated osteoclasts and fibrous tissue from severe hyperpara. But that's not typically what we see in the United States now with hyperpara. How about the typical skeletal features of hyperpara? So remember that the skeleton is broken down to the cortical shell and the trabecular meshwork inside the bone. And what was discovered many years ago is that hyperpara affected the cortex a lot more, thinning of the cortex, with what we thought was preservation of trabecular bone. And there is data following patients. And the basic thing, people with mild hyperpara, is that for 10 years, for the most part, most patients, their bone density was stable. In the Columbia 15-year data, there seemed to be some decrease between year 10 and year 15, but the number of patients left by then was very small. There are a couple randomized trials with hyperpara, and all of them showed the same thing, that when you operate on people with hyperpara, the bone density improves. If you don't operate on them, the bone density is largely stable, at least over 1 or 2 years. That's good news. So one thing that's not known is if the relationship between bone density and fractures is the same. It appears, as it is in osteoporosis, it appears that baseline bone density is more decreased at cortical sites than it is at trabecular sites. Well, how about fractures? So this is, on the left here, these numbers are from an observational study from the Mayo Clinic from many years ago, and they looked at the relative risk of fractures at various sites in their patients with hyperpara. And as you can see, they were elevated. These two columns are from a study from Scandinavia, and these are patients with substantial hyperpara, mean calcium 11.8. And as you can see, their relative risk of fractures was increased before surgery and then came down after surgery. The interesting thing is that vertebral fractures were increased. And if trabecular bone is so preserved, why are we seeing vertebral fracture increases in both these studies? And so people then moved on to more sensitive techniques. So people did some things with high-resolution peripheral QCT, which is not clinically available, but is a research tool, and found, yeah, there are trabecular defects. What's more practical is the use of trabecular bone scores. Now, the people now see, I know that St. Agnes reports these. You see this on the bone density reports, trabecular bone score? Trabecular bone score is kind of a cheap way to look at bone microarchitecture. And it is an independent predictor of fracture. And you'll see it now reported on your bone densities, and you can actually, there's no charge for it. It's just a software analysis. It's done automatically. And people use FRAX for evaluation of osteoporosis patients. At the end of when you do FRAX, they'll say, do you want to adjust this with trabecular bone score? You can click that and then adjust it with trabecular bone score. And you'll see in patients at the extremes, it could change you from a treatment to a non-treatment or vice versa. So as it turns out, trabecular bone score, reflecting trabecular health, is reduced in primary hyperpara. It's associated, the lower it is, with vertebral fractures and hyperpara, independently of bone density, and improves after curative surgery. And this is kind of what it is, trabecular bone score. So this is somebody, these two people have the same bone density. This is someone with normal trabecular bone score, and this is somebody low. And you see there's more irregularity. It's like looking at a forest with areas that are cleared out. And this reflects weaker bone. So randomized trials show bone density increases after parathyroid surgery and is stable without surgery. The Columbia prospective data suggests stable to 10 years but decreases 10 to 15 years. Bone density, fractures probably are increased, and trabecular score is associated with vertebral fractures and may explain this increase in vertebral fractures that we're seeing. So the sum of that is we used to think hyperpara just had detrimental effects on cortical bone, but it does have detrimental effects on trabecular bone as well. How about kidney stones? Well, in the old studies, before there was multi-channel screening and hyperpara was diagnosed, when you presented with something, 40 to 60% of patients had kidney stones. It's now much lower. And it's clear that patients with stones, hyperpara decreases stone events. But now there have been some studies that suggest that asymptomatic patients with primary hyperpara have increased risk of stones. In this study, 7% compared to 1.5% in controls. And then a recent study from Italy which suggested half their patients had kidney stones. So that's kind of changed the approach to extend the evaluation of patients. Now, other thing that's gotten a lot of attention is cardiovascular. And if you look at more severe hyperparathyroidism, mortality is increased, but that does not appear to be true in mild primary hyperpara that we typically see. And then there are these associations: hypertension, LVH, increased carotid intermedial thickness, increased carotid stiffness, increased aortic stiffness, heart calcification, vascular function. These are all associations. Well, there have been some randomized trials. And in this is a study, this was 116 patients evaluated at 2 years. There was no difference in blood pressure, markers of insulin resistance, or lipids. In 50 patients evaluated at 2 years, minor effects of surgery on echocardiographic parameters. And then another study of 50 patients at 1 year, the baseline echo was normal and no change in either group. So I would say there's no clear improvement suggesting a cardiovascular benefit in the typical mild primary hyperpara. And so cardiovascular disease or cardiovascular risk is not a current indication for surgery. That said, absence of proof is not necessarily proof of absence, so there's still a lot of smoke out there. The other thing is the neuropsychiatric stuff. So classical hyperpara has prominent psychiatric and neurologic manifestations. That's the more severe hypercalcemia. Whether subtle symptoms are part of the mild disease is controversial. There's a lot of observations: anxiety, depression, decreased concentration, and so forth. The issue is attributability. So depression and neuropsychiatric abnormalities are present in many studies, and non-randomized trials suggest improvement. The randomized trials are very inconsistent. And when you see a difference between observational and randomized trials, it could suggest selection bias. So what I think if a person has significant depression and neuropsychiatric abnormalities, I would strongly consider surgery, but manage the patient's expectations. I tell them it's a coin flip as to whether they're going to get better, because I think it's pretty soft data. So a few years ago, there was a consensus panel. This is the place where it occurred in Florence. This is the outside where we had our breaks, beautiful palace built in the 15th century, and frescoes on the wall. It's gorgeous. And out of that came a bunch of consensus panel suggestions for evaluation and management of asymptomatic hyperpara. They're all published in the Journal of Clinical Endocrinology and Metabolism in 2014. So what's the evaluation? A chemistry panel. You have to add a phosphorus to it. PTH, a vitamin D, a DEXA. And remember that cortical bone is the bone density is sometimes worse. So the recommendation is spine, hip, or radius, and radius. All three sites should be done. A VFA or spine films. And the reason for that is that some studies have found an increased risk of vertebral fractures. So VFA is done with a DEXA for vertebral fracture assessment. I don't think St. Agnes has it on their equipment. But it's basically a lateral view of the spine with almost no radiation and almost no cost, where you can evaluate for compression fractures. Alternatively, you can just do spine films to look for compression fractures. A 24-hour urine for calcium and creatinine, and that's to exclude familial hypocalciuric hypercalcemia. Some imaging of the kidneys. I find it hard to do a CT on a bunch of asymptomatic patients and the cost of radiation, so I usually do a KUB or an ultrasound. So when should we consider genetic testing for some of these familial conditions? So this is a study looking at 86 patients under the age of 45 with apparently sporadic hyperpara, clinically non-familial and non-syndromic, and 9% had mutations, germline mutations of one of these. Another study of patients with FHH, and these are people with proven calcium sensing receptor mutations, and compared them to 97 patients with hyperpara. And we used to say the calcium creatinine clearance ratio of less than 0.1 and 0.01 in FHH. Well, as it turns out, to exclude all the FHHs, you have to go to a higher level, less than 0.02. And there's going to be huge overlap. So this is some of the thinking behind the recommendations that the panel came up with that I'm now going to show you. So these are all the genes that have now been associated with hyperpara. It's like all diseases, it gets broader and broader. If you look at the paper, they'll give you this table for who should have genetic testing. So I'm going to just tell you what they're saying in a few words. They say you should consider genetic testing if the patient is young, less than 45. If they have parathyroid cancer, if they have multiple gland disease, more than one abnormal parathyroid, if there's evidence of familial disease, or if they're syndromic, that is associated with some multiple endocrine neoplasia or something like that. It's a pretty big group of patients. And then when should you do genetic screening to exclude FHH before you send someone to surgery? Well, they say if you do the calcium to creatinine clearance ratio and the GFR is greater than 60, and the calcium to creatinine clearance ratio is less than 0.02, you should do genetic screening. Well, that's a huge overlap in patients with primary hyperparathyroidism. Further, many patients that we see with primary hyperparathyroidism are old, and their eGFR isn't greater than 60. So my kind of thing is, what I say is, look at old labs, get family calcium levels, not just family history. Sometimes you've got to actually get the blood tests on people done. But if you look and you see, well, gee, 20 years ago their calciums were 9, 9, 9, 9. Then about 10 years ago it started to go up, and now it's become ill. It's not FHH. FHH is not an acquired disorder. And so you can, I think, make a clinical decision based on that. So who are the patients that should have surgeries? Now, anyone can have surgery, but what they said is these are the patients that should definitely have surgery. And they use a calcium 1 milligram per deciliter above the upper limit of normal, T-score at the hip, spine, or radius less than minus 2.5, vertebral fractures on imaging. They say eGFR less than 60. I'm going to tell you, I ignore this for the most part, because what that means is the 65-year-old who doesn't need surgery now will definitely need it at 85 because their eGFR will be less than 60. It doesn't make sense to me. It should be adjusted for age. If they have increased stone risk by a stone risk panel, or if they have kidney stones, and if they're less than 50. These are the people that definitely, they say, should have surgery. Everyone else, of course, is a candidate for surgery. If you're monitoring patients, you should check the calcium and kidney function yearly, a bone density every 1 to 2 years. And you may, if there's any other reason, re-image the person for their spine, for vertebral fractures, and the kidneys for kidney stones. When would you then send a patient to surgery who you were monitoring? Well, if their calcium gets above the limit, if they develop osteoporosis, vertebral fractures, clinical development of a kidney stone, and then again, they say this creatinine clearance less than 60, and I have a problem with that. And so I'll be honest, I do not use that one. So how about normal calcemic primary hyperparathyroidism? I hear this a lot. And normal calcemic hyperparathyroidism, it makes sense that it would occur because the normal range for calcium in a population is much broader than the normal range for an individual. This isn't, if you measure it multiple times in an individual, this might be the normal range for an individual, whereas this is the population normal range. And if this individual goes up to here, they may be developing, for them, hypercalcemia. It makes sense. There were reports of this decades ago. This is from 1969. Dr. Barter is one of the well-known big names in this field. So, what I'm going to kind of summarize to you and then try to give you a word of caution. Normal calcemic hyperparathyroidism occurs. It's less common if those with elevated ionized calcium or intermittent hypercalcemia are excluded. Recognize 2.5% of a normal population will have an elevated PTH. And PTH is related to renal function, goes up with fat mass, it goes up with age, if they don't take much calcium or have calcium malabsorption, and vitamin D status. Most of these patients have an elevated PTH found during evaluation of a low bone density. And the definition is multiple elevated PTH levels with persistently normal albumin-corrected and ionized calcium. These are the Columbia criteria. You have to rule out secondary hyperparathyroidism. The 25D has to be more than 20, preferably more than 30. And remember that if you correct somebody with secondary hyperparathyroidism due to vitamin D deficiency, you get them up to 30, It may take months for the PTH to normalize. It doesn't just correct immediately. GFR more than 60, you have to think about medicines that increase parathyroid hormone, lithium, thiazides, and Prolia or denosumab. It's very common for PTH to go up after a shot of denosumab. You need to consider diseases that increase PTH, like increased bone formation, Paget's disease, and blastic metastases. You need to rule out malabsorption and rule out marked hypercalciuria, because renal leak hypercalciuria can be associated with elevated PTH and secondary hyperparathyroidism. It's a variable course. Some become hypercalcemic. Bone loss is common. If you look at the literature, multiple gland disease appears to be more common than in the typical hyperpara. Long-term follow-up is not available. There is some data that bone density improves with surgery, and it, like typical hyperpara, also improves with bisphosphonate therapy. There are also cases where PTH remain elevated after surgery. So you go in, they have a calcium of 9.5 and a PTH of 90. You operate, now they got a PTH of 88 and a calcium of 9.3. I don't know what you've done. What do you tell that patient? You now have really normal calcemic hyperpara? And I've seen this. The first patient I sent to surgery was normal calcemic hyperpara. So if the only need for surgery is bone density, you could consider an anti-resorptive agent. If the only need for surgery is hypercalciuria and stones, you could see if putting them on a thiazide brings out hypercalcemia. This diagnosis should be made with great caution, and these patients really need to see an endocrinologist with expertise in hyperpara. So who should have parathyroid surgery? Well, the cure is 95 to 99% in sporadic, lower with reoperative surgery in people who've had neck surgery. Risks, anesthesia, hematoma. Permanent recurrent laryngeal nerve injury in a virgin neck, less than 1 or 2%. Reoperative, it's higher. Hypoparathyroidism, again in a virgin neck, less than 1 or 2% in experienced hands. But if you look at reoperative cases, as high as 10 to 15% in some of the literature. And Dr. Udelsman, who's one of the big parathyroid surgeons, says the threshold for surgical exploration should be higher in reop due to inherent difficulty. So the risk-benefit ratio is not the same if someone's already had neck surgery. So modern surgery makes surgery more attractive for most patients, certainly symptomatic patients, certainly those who need guidelines. I would strongly consider it in patients with depression or neuropsychiatric disease, and in many others for that matter. Be cautious. The biochemical diagnosis is not secure. The patient doesn't want surgery. Poor surgical candidate, very old with a short life expectancy. And if it's a young patient, it's not that I wouldn't recommend surgery. I would consider genetic testing first, because it may affect the surgical approach. Remember that in some of the familial diseases, multiple gland disease is much more common, and the surgeon may have a different approach to that. I would be cautious in normal calcemic hyperpara. As I said, this diagnosis should be made with great caution. I'd be cautious if they have prior neck surgery. Need to know what was done and about parathyroid glands removed. So I saw a patient recently that the internist said, "Do you want to see the patient?" I just sent him to the surgeon. I said, "Let me see the patient." Well, as it turns out, the patient had a failed parathyroid operation, but they took out 3 normal parathyroids. Experienced parathyroid surgeons don't take out normal glands, stay in place. And I said, no. This patient, hypopara, is going to be a whole lot worse than hyperpara, so I would not send this patient to surgery. Remember that hypoparathyroidism is a much worse disease than mild hyperpara. There's a lot of data on that. Be very cautious. The patient's had bariatric surgery or has had severe bowel disease. In these patients, hypoparathyroidism could be a disaster. There are several reports of patients requiring continuous hospitalization who've had bariatric surgery and now have hypopara. Some of these patients have had to be reconnected with their gastric bypass. So surgery, one last thing, localization is not a substitute for an experienced parathyroid surgeon. So how about medical treatment? You know, people always say, you know, don't stop your calcium and stop your vitamin D. Well, there is data that vitamin D is safe in patients with mild primary hyperpara. And there's even a randomized trial that showed that with 2,800 units a day, the vitamin D went up, the PTH went down, bone density went up a little bit, and there was no difference in urine or serum calcium. There is some data that in some patients, in a different study, serum and urine calcium went up in a few. So there's a modest decrease in PTH, increased bone density. Few patients have increased serum or urine calcium. But what I wouldn't apply this to is a patient with a calcium of 13. So you have 10.5 and the PTH is 18, I don't have any problem giving them 1,000 units a day, trying to get them up to the high 20s. But if their calcium is 13, I'm not sure the same thing applies. That study's not been done. So I want to just remind you that the calcium sensing receptor is on parathyroids and renal tubules as well as other cells. And there's a drug which is an agonist for it. So it's called cinacalcet or Sensipar. The nephrologists use it all the time. And it's a drug which tells the parathyroid the calcium's higher than it is. Parathyroid hormone goes down. And then theoretically, calcium would go down. Well, the nephrologists use it for secondary hyperparathyroidism or renal failure. It is approved now for parathyroid cancer and severe hyperparathyroidism, as well as end-stage renal failure. And this is a study in patients with mild primary hyperpara. And just to show you, this is the calcium, went down nicely. There was no change in urinary calcium or bone density. And I think that's important to know. This is a small study in a handful of patients with severe hyperpara who could not or would not have surgery. And they required higher doses, but also they were able to get their calcium from 13 to the high 10s. Further, all these symptoms improved dramatically. So it is, I have done this in one patient with severe hypercalcemia who absolutely refused surgery and has responded well. So if no surgery, avoid dehydration, immobilization, avoid thiazides and lithium. A normal calcium intake. So calcium restriction is not recommended. And that counts the food. So 1,000 milligrams, if they have 3 glasses of milk a day, they're already over 1,000. But counting food, normal calcium intake of about 1,000. Try to keep the 25D greater than 20 to 30. Anti-resorptives like bisphosphonates can be used for bone, but they have no persistent effect on the calcium. The calcimimetic cinacalcet can be used for significant hypercalcemia if you need it for the calcium, but has no significant bone density effects. And of course, the monitoring we talked about before. So let's go back to this patient, 68-year-old, asymptomatic, no stones. Hypercalcemia has been going on for a long time. Her calcium is 10.9, urinary calcium on the low side, and PTH is normal. So we stopped the thiazide. Her calcium, as typically happens, stayed the same, as did her phosphorus, creatinine, and PTH, but her urinary calcium went up to a more typical range for hyperpara. So the lessons from this, and her femoral neck bone density is minus 3.1. She has osteoporosis. So the lessons, it is not uncommon to see parathyroid hormone in the upper part of the normal range in primary hyperpara, but it's inappropriate in the setting of hypercalcemia. It should be suppressed if the hypercalcemia is PTH independent. About 15% of patients with primary hyperpara have PTHs in the upper part of the normal range. Most patients with thiazide-associated hypercalcemia have underlying hypercalcemic disorder. So this is a patient who's got osteoporosis. She meets criteria. We recommended surgery. She refused. So this is a patient who I would consider a bisphosphonate, because the only thing that she really needs is to kind of help her skeleton. I would not use something to lower her calcium. She has asymptomatic mild hypercalcemia. So that doesn't really need any specific treatment. So to summarize, I'll finish up. Hypercalcemia should be divided into PTH dependent and PTH independent. Occasionally the laboratory data is misleading. Don't forget biotin. And that's for lots of assays it messes up. Skeletal effects of hyperpara probably increase fractures, affects both the cortical and trabecular compartments. Bone density improves after curative surgery on average. There appears to be an increased risk of undiagnosed kidney stones. The significance of cardiovascular and subtle neuropsychiatric changes are still unclear. And there are these recent guidelines that are I think, very clear. Surgery is best done by an experienced parathyroid surgeon. If a patient, in patients that don't need or won't have parathyroid surgery, avoid dehydration, avoid meds that increase the calcium, adequate calcium and vitamin D. Anti-resorptive therapy can be used for bone density, but doesn't change biochemistry. Cinacalcet can be used to lower calcium, but doesn't improve bone density or urinary calcium, and monitor the patients. And I think I'll stop with that. Thank you very much.